One small thing, Siddharth, as I'm saying the housekeeping rules, perhaps you could just type them in the chat also. So especially if I miss something, then people can see it for sure from you.
Yeah, sure, Dev.
Yeah, okay. Thanks. Hello, everybody. Greetings from rural Kerala. My name is Devaki Nambiar, and I'm very pleased to welcome you all to this very special session on system dynamics modeling for health systems strengthening. We're absolutely delighted to have the lineup that we do today in a collaboration with the Systack Accelerator Group, the George Institute, and our wonderful colleagues from Thailand and Bangladesh who are joining us today. So it's my privilege to introduce our first keynote speaker, who is Dr. Borwornsom Leerapan. Dr. Leerapan, or AK as we call him, is Associate Professor at the Ramathibodi Medical School of Mahidol University in Bangkok, Thailand. He's a preventive medicine physician and a health systems researcher, and his interest is in healthcare organization studies, and in particular, his expertise has been in applying complexity sciences in health systems governance and hospital and healthcare management. He has his master's in science in health policy and management from Harvard, and also a PhD in health services research from the University of Minnesota. We have had the good fortune of collaborating with him recently on developing our ideas, capacity strengthening, and even proposal writing related to systems thinking, and benefiting from his wisdom in this process. Apart from this, of course, he serves a number of other roles, including as Deputy Director of the Center for Health Policy at the Faculty of Medicine in his hospital, Ramathibodi Hospital. And he also serves on the Scientific Advisory Committee of the Prince Mahidol Award Foundation, which is under Royal Patronage. So we couldn't be more delighted to welcome Dr. Ak to this special presentation, where he's going to talk about applications before and during COVID. As Siddharth has pointed out, a little bit of housekeeping. We request you to please be muted. And also post your questions in the chat box. Sorry about the noise. I will definitely mute myself also. Following Act's talk, we will be hearing from Dr. Sohana Shafiq from ICDDRB, who will be introduced in due course. So without further ado, I'd like to turn over to Ak to lead us through his reflections. Thank you so much for being here.
Thanks, Devaki. Good afternoon from Bangkok, and good evening, good morning from people from different time zones. Thanks for having me here. And today I'm going to share briefly about maybe 20 minutes or so my work that could be answer how a system thinking tool called system dynamic modeling can help support the health system learning process in low and middle income country like Thailand. And perhaps we can focus a bit more on the COVID context. And so this is the lesson learned together. How could we help each other to sort of popularize this kind of methodology in health policy process? So without further ado, let me share the slide, please. So can you see my slides okay, right? All right. So we won't have some sort of 1.5 hour for lecture. It's going to be some sort of presentation, and let's talk about it later. So I'm going to go over 3 points here. Maybe you need to introduce a little bit of what actually system thinking is for people who who are not familiar with it. And system dynamic modeling is a tool for system thinking, what it is for people who are also not familiar with it. And then we're going to go over why we should use it as a tool for health systems training in the context of Thai healthcare system, universal health coverage in Thailand, and also how our health system adapt to COVID with help from this decision-making tool, some people might call policy decision lab. And on the how, we're going to explore how systematic model can be conducted with the process of group model building. What exactly it is, I'm going to explain a bit later. And of course, we're going to see the case study from Thailand, both before the COVID and during the COVID pandemic. And then let's have a Q&A and discussion about it together. So first thing first, what exactly it is, system thinking. I would say this is kind of thinking about thinking. So it's a bit abstraction. If you Google it, for people who are not familiar with it, there's so many definitions out there, many article, textbook written about it. For today, I'm not going to talk about it, all the definitions and things like that, but let me share you guys the story. It's actually my story as a doctor, a young doctor in Thailand after graduate from medical school, and how I have encountered something that my needed system thinking. So if you think about Thailand health system challenge, 50, 60, 70 years ago, it's going to be something like this, just like many other countries, low-income countries, that we lack of resources. This is actually a picture taken nearby the Don Mueang International Airport in Bangkok, the old Bangkok airport that now used for domestic routes. You can see this is pretty much nothing, right? And that's the airport and air transportation. Same thing with the healthcare system. Problem back then is basically we lack of the resources. We need to outreach to the people in rural areas and things like that, both for healthcare in the hospital, outside the hospital, and also public health services. And then if we move forward to something around the year 2000, which is basically about the time I graduated from my medical school. I graduated in 1999, and this is basically my my daily working life as a doctor. Crowded people at the outpatient department in the hospital. So this is not any kind of festival. It's kind of regular activities within the public hospital in Thailand. So you can imagine how much time you have to see one patient and how much it's going to convert to not so good quality of care. And then that's going to create a kind of vicious circle, and people have to come back to see you again and again, and a lot of workload and things like that. I start to wonder, what can I do? Should I do more than treatment? Or, you were taught that just treating patient is not enough. Maybe you have to do health education. I just did that. Sometimes later, I becomes acting hospital director. I need to do the management as well. So I just did that, create some work, do the health promotion in the community. That's no drink and drive campaign during the Songkran holiday, the Thai New Year. I go to raise the funding from the community to renovate my emergency room. But I just try to do my best, basically. The result is just here. Same thing, again and again, a lot of people crowded at the hospital, and I don't think I can do good enough job providing a good care for them. So I keep this question for a while, and without any training in public health back then, I got something from my med school, which is a doctor was taught to treat not just symptoms, but to diagnose the disease first, to see the real root causes of whatever symptoms that people presented to you as a patient. So I guess I have in my mind back then that maybe crowded hospital or less resources to provide a good quality of care for everyone. Maybe that's something of something deeper. And there may be some root cause of the disease, but it's not a disease of the patient, but disease of the population. So I keep that in mind, and after my grad school, I just learned that, well, this is something people call wicked problem or complex problem. Some problem that doesn't seem to be solved easily. You have to think through it. Otherwise, some solution actually lead to even worse problems or new problems. Like we can create new hospital, but it's going to be another crowded hospital induced demand, and people going to be not healthier, just you expand hospital more and more, just like Thailand has been doing for 60 years, right? So to summarize that, I've been teaching this day. From what I have learned along the way, I conclude into my own definition of, well, by the way, this is called system thinking in the literature. But to me, when I teach my student, I would say at least they have to have 3 components, which is to think at the complete big picture, and then also think about the underlying causes, and also think about the long-term consequences, not just a short-term solution and how things go in the short run only. In Thai, it's called Kit Kop, Kitลึk, Kit Yao. And I've been trying to advocate for this, doing research to use this perspective, and brought along some methodology that can help us to think the complete big picture with the underlying causes with the long-term perspective. So if we can do that, It's gonna be like we have see the big picture of the animals right here, which is not an elephant, right? You can see only the head of the elephant or a part of snake, and then fans, tails, spear, things like that. There is no elephant in this picture unless you see the complete big picture. Otherwise, this is the way we usually working in medicine and also public health. People try our best with the background and training and experiences that we have. We have some ability to access to the complex problem, to the phenomenon, in this case called elephant, but we all have blind spot. And that's why if we're not talking to each other and sharing the information and synthesis the big picture, we always correct the problem at the wrong side, right? The solution is you try to avoid compartmentalized thinking. You have to zoom in and zoom out to expand the system boundary to fit the problem, the complex problem that you try to solve. That's the first thinking concept that I kind of assert, that we have to think about the big picture. But as important as the first one is actually you have to think deeply about what actually create the problems behavior that you can observe. Because under the water, using the iceberg analogy, there are lots of things that you might not be able to observe easily, but it's actually the root causes that drive the pattern of behavior that you can observe, the structure that create that pattern of behavior, and the belief, the values, the assumption of people within the health system that actually create system structure that force behavior again and again, as we see in this case, why people are so crowded and why we don't have enough doctors and healthcare personnel to treat the patient with effective care. So there's going to be a lot of tools that can help us dig deeper, and I'm going to share a part of it today. But basically, if we dig deeper, we're not going to react to the problem. We might be able to predict, to design new system, and also to transform the health system to a better place. Lastly, hopefully we're not being a good, we're not a bad manager that try to solve the problem just for the sake of solving the problem, because when the problem gonna create adverse consequences, we're gonna get promoted to somewhere else already. If we think from the long-term perspective, to see the whole health system development for our next generation, some tools gonna help us see if we do this 10 years from now on, how things gonna be happening. And also we can prevent some mistake, like avoid something that is actually worse, but it's gonna get better. Or try to do something that actually better only in the short run, but gonna getting worse in the long run, for example. So that's the concept, which can be quite abstract, so many people. How researcher or scholar or sometimes policy analyst and healthcare manager can do with the data to support policy making process, and also implementation of good projects that we were talking about in the context of health system training. Today, we don't have time to touch up on every tools available, but you have enough resources. At least check out on the website of Systack and our network. The WHO Alliance for Health Policy and System Research also have a good resources on that. I already talked about it a little bit, like iceberg model, and we have robot time that we have to think about the long term. But in health policy process, sometimes we can start with thinking seriously about the problem that we so concerned about. For example, why Thailand has a continually have a congested hospital? Is that shortage of personnel compared to the health demands? And how would that be for the last 10, 20 years? And how going to be in the next 10, 20 years, for example? That's called BOT, or behavioral time graphs. We can think about that seriously and talk with a lot of people to synthesize the causal mapping that actually explain the behavior over time graph that we just created. For this part, sometimes it stop here with a better understanding of what actually causes the problem. It will consider system thinking tools as well for the first two, but you can go to the third one, which is actually develop a quantitative modeling, and you can simulate it with or without policy options, then the current policy compared to the policy you propose, and see how would that change the behavioral time if nothing has been done. And for this, the third part and the fourth part is actually system dynamic modeling that we were talking about today. Some basic is actually the metaphor that Professor Jay Forrester from MIT, who created system dynamic modeling years ago, used to teach students that everything under the sun can be seen in two aspects. Either is the level of the water on your bathtub, is called stock, is a certain amount of quantity of something at one time. And that can be changed only when you open the pipe, either inflow or outflow. If this thing, the water is something good, you want to increase it, the only way you can change the policy is turn in the pipe and then maybe stop or slower the outflow, right? On the other hand, if this stock is something bad, you just do the opposite. Turn on the outflow faster and maybe try to stop the inflow. That's basically the concept of systematic modeling. And then you share it into computer modeling using a differential equation, try to do model of this kind of stuff. And eventually you can play around the menu of policy that you can improve the inflow and outflow of the stock that you're concerned about. For example, this is from CDC of the US years ago, called HealthBound. They want to create experiment on how the policymaker could improve healthcare system in the US. Some people would call that policy decision lab. And you kind of play around which option is better. Of course, each option has some cost. We have limited budget and resources. How would you allocate it? And play around, would the result be better in terms of death, healthy days, equity, and also expenditure, things like that. This kind of modeling or policy design lab actually more and more important in complex problem. These days, the group from MIT actually tried to do this with climate change. We just finished the COP26 very recently, right? It had been argued that these two have been used to advocate on the both sides of the aisle, both conservative and progressive, try to come to understand the complex problem of climate change and actually not just being politicized by it, but try to find a middle ground or whatever works together to reduce the temperature that has been increasing. So this is kind of concrete of the abstraction of system thinking, but how it can be done in the context of health systems learning. Before the case study, I'm gonna introduce you to another concept called group model building. So system dynamic modeling is actually the technical analysis using segregated data to do simulation quantitative modeling, as we discussed. But the way to gather the data and structure the model, the logic behind it, has to be acquired by implicit knowledge and explicit knowledge of the stakeholder and policymaker getting involved in that problem solving. So to do this more effectively, a lot of scholars in system science actually try to engage stakeholder and policymaker in the process of building the system dynamic modeling. So rather than modeler or researcher do this alone, we engage with people who are concerned about the problem and try not to be the blind man and try to palpate the elephant, but we work together and we're gonna see the big picture, understand the root causes, and maybe think more about the long run. In other words, if we do it alone without engagement of people who are concerned about the problem, sometimes they can throw away our ideas from the model because they don't understand the model. They thought about it as a black box. So maybe we are not good enough in terms of modeling. We miss something and garbage in, garbage out with invalid data. Our finding is not going to be valid anyway. So why not engage our policymaker and stakeholders since the beginning of the process of system dynamic modeling? The perception could be better and the usefulness could be enhanced as well. So I'm going to elaborate such process by the case study of Thailand. Several years ago, I was contacted my colleagues in the Ministry of Public Health, try to help understand the workforce planning better in the longer perspective using system dynamic modeling, which is actually something I'm curious about for a long time, right? Because I asked since I was a recently graduated medical doctor, why we keep having a lot of demands for workforce in the rural area, and that hasn't been solved for a long time. Turn out that maybe in the past, we usually think compartmentalizing. Doctor planning the quantity of doctor without concerning the number of nurses, pharmacists, public health officer, even though in fact we work together as a team serving patients out there, right? And sometimes we just fill in the position in public facility using historical based planning process, rather than thinking about what actually the new demands, how about the future of digital health can impact the use of workforce, how about the NCD change the demand to a different kind compared to 50 years ago when most of health demands are infectious disease. And then what is option out there? Try to compare among scenarios that could be better compared to only one plan scenario that could be argued against, and then maybe move not so moving for many stakeholders in the process. So if you do the literature review on strategic workforce planning for any country, before you can develop workforce in terms of quantity and quality, you have to think more about what actually those workforce work in, what kind of service. Is it primary care, long-term care, acute care, intermediate care, palliative care, for example? If not, we're going to produce the workforce that is not hired by the healthcare organization or public health organization, right? And then the service itself has to be transformed according to the population health demand. That could be changed from time to time. As I said, with the epidemiological transition, we need a different kind of service. That's why we might need a different kind of health workforce as well. So we repeat the process of 4 steps that I just shared with you. I go to engage with stakeholders in the public health and some private sector, some scholar from university, explain the two called causal map or causal diagram that I just mentioned earlier, having them dissecting the data from Thailand and why doctor, nurses, pharmacists in Thailand keep insufficient to the health demand. A lot of good points have been raised in the group model building workshop, including maybe not just quantity, but what's the focus that those people try to provide to the population, including health literacy. How about the behavioral overtime on those variables? And we touch upon the concept of healthcare model. This is the graduates, the medical school that I graduate from. Is if you ask me which building is a hospital, is a wrong question, because every building in this picture actually belongs to one hospital. Systack Hospital is a big hospital, 2,000 something bed, and it keeps expanding, and people still don't think we have enough doctors. So there may be something wrong about it. Perhaps we have enough hospital, but lack of non-hospital care like primary care, rehab center, palliative care, end of life, long-term care, even dental care, and also population health kind of thing need to be revised as well. We need a different kind of workforce for public health services in this digital era. So after a series of workshops, my team and I actually try to get all the data and we synthesize them into causal mapping, the step number 2 in our diagram, right? With this kind of roughly drawing, and then I turn this into a more refined computer drawing, even it's still very, very complicated. I actually spent about 10 minutes explain this to the Minister of Public Health. I has been told that maybe this is too much for him, but at least we learned something from this process, which is before that we actually don't have the mutual goal of what is enough healthcare workforce planning. In other words, we don't know when it's sufficient. So at least not me or our research team, but all stakeholders engaged in the workshop say, at least we have to have the optimum population per workforce ratio, minimum unmet health need, including waiting time that you see in the first picture I shared with you in the public hospital around the country, and also try to maximize the health status and quality of life as well, particularly quality of life, because for some people you can make them better. Like elderly or the disabled people, but you actually can increase the quality of life with a certain kind of care, like long-term care or palliative care. And of course, without bankrupt the country, we have to control the healthcare expenditure while increasing the workforce as well. So we change from the CLD causal loop diagram into stock and flow diagram, the bathtub analogy. Go back to stakeholder once again, and you can see that bathtub is on the wall. We engage with stakeholder, how they see it, what should be changed, what could be added, what's the value that my team and I was missing, and they can point it out to the database that need. And eventually we run a simulation modeling. You can see different color, represent different scenario. And we propose, if we have done nothing more, the business as usual. How about the outcome of healthcare workforce in terms of quality of life of Thai population, the unmet health need and expenditure. And we present this to the Minister of Public Health and also the Deputy Minister of Education, who actually accountable for the production of healthcare workforce within the country. I have a chance to share this with our international audience a little bit as well. So we just go at zero in New Delhi. So not many people in our region has been doing this job. So it's a good chance to share what we have been doing as well. And if you're interested in this work, we also published it. It took quite a while, but it just came out early this year on human resource for health. So what we have learned is actually there's a lot of good thing if we engage with good methodology. We have a mutual goal. We introduce the concept, so people don't be afraid to try the new things. And at least we establish a new way of working as a healthcare workforce or human resource for health coordinating unit within the Ministry of Public Health. Hopefully, we keep doing that as a policy decision lab for this work matter. So that's the first case study before the COVID. The question is, what has been changed after the COVID, or what it can be applied in a different way? So I'm going to go a bit quicker for this case study, but I need to share some background for people who don't know the situation in Thailand. Last year, 2020, we did pretty good actually. COVID hit Thailand early, and we actually the second country who accept a lot of people after Wuhan, China. But we control it pretty well with collaboration with people around the country. But you see the social distancing, testing, with the worker and drive-through. Chatuchak market is closed for cleanup. Airplane become empty, and this is famous Phuket Island tourist destination all closed. This is not any. There was no vaccine back then, but this is people waiting in line to get the subsidization from the government because they lost job. So a lot of complexity because you control the disease pretty well last year, but actually Thailand is actually one of the best country in terms of disease control, but one of the worst in terms of socio-economic consequences, partly because we depend a lot on international tourism and international trade. That's why people so suffering. So what can be done using system dynamic? So traditionally, we can use system dynamic to do the epidemiological modeling. Sorry for the Thai, but basically it's susceptible population, exposed, infectious, recovery, death. We can project that. And then we can try to insert the policy, as I said, how would that change the pipeline inflow and outflow of something we don't want? We don't want people to die, to get infected. We want people to stay susceptible. We don't want people to get imported from the outside. And how could we prevent infectious people to meet with a susceptible population? There are a lot of policy can be taking place, including the downstream actually rapidly increase the healthcare capacity in case we got so many cases. So we're going to prevent unnecessary death. And sometimes need to lock down as well, right? So my team and I actually engage with policymakers and also talk with mass media. And we use systematic modeling to communicate that the Thai people can do so many things besides just stay home and wash hands and wear masks. We need innovation, digital health in terms of contact tracing. We need innovation in terms of how to do the mass gathering safely. New kind of social distancing for small business, for example. And of course, I also do the EP model to support the policy making. A part of our finding actually get presented by the government to project how fast we can open the city last year. However, last year maybe we did too much about the dirty bomb. We shut down the city, so a lot of collateral damage. We need to do a better job to do a smart bomb, which is the contact tracing. Quarantine only people who are at high risk and try to get back to the new normal as soon as possible. Unfortunately, this year, a lot of things has been changed. This is basically Delta and Alpha strain actually difficult to contain, and we have a different kind of problems. Basically, infection within a small, densely populated area within Bangkok. And then it's just too difficult for these people to do the social distancing, right? So it become difficult for different population, and we need to customize the policy to do a bit better job. The modeling can help to see if we do enough in terms of acute case finding to compare the asymptomatic cases that we predicted to the cases we actually detected. And eventually we can match the demand, the predicted number of infection to the few hospital needed in that particular moment, including the ICU, because if ICU is overrun, a lot of people are gonna die unnecessarily, avoidable, preventable, unfortunately. So we did some simulation modeling and share with it on the website. If I have enough time, I can share with you right here lively. You can change the policy option, tick this and change and see how the EP model can be changed. And we try to communicate this with our policymaker and mass media via the social media as well. Turned out that some people quite interested about it. And we still keep working on this to this day, including not just EP model in a normal way, but if we add vaccination, how can it change the complexity of the epidemic control? So I guess we have learned from exercising system dynamic modeling as a system thinking too, that we can understand more complexity, more of the complexity of the epidemic. And obviously we did pretty well last year, but not so well this year. And the model can show that a lot of things can be improved. More or less, we need to do a lot better in terms of not delay rollout of appropriate vaccination program for the vulnerable population, and build a better infrastructure of testing, tracing, and isolation the cases. Of course, we need to learn because this is VUCA, right? And learning ability is actually the key for health system resilience. Just like we were talking today, I think policymaker and health system administrator can do a lot better job with our scholarly support, system thinking tool when needed. So we can contribute to solve complex problems either before or post-COVID. A lot of literature talking about this. I'm gonna skip it, sorry. But to me and my team, we can do a lot better, not just decision supporting to in the policy making process, but whatever has been done has been the policy already in place. We can compare to the predicted result from the model as a way to use as a monitoring and evaluation of the policy implementation as well. So I guess that's my presentation that hopefully provoke some idea and discussion later on. We can use system dynamic as a tool to support policy decision making or policy decision lab. And with the group model building, we can engage stakeholders to get the insight and also create an ownership of our work as well. Mostly, you can see from our workforce planning that the option is actually perform well. It's not going to be just solving superficial problem, but it requires system change. For example, not just adding healthcare workforce, but to reform the healthcare delivery to match the population health demands in the future. Same with the COVID-19. You need to think both short-term and long-term, and also public health and healthcare surge capacity to prevent ICU overrun as well. So I'm gonna end with a classic quote from George Box. You probably have heard this. All models are wrong, including my system dynamic modeling, but hopefully some are useful. And that because the complexity out there, the reality is so complex to represent by any model. But we build a model right, in the right way, engaging with people. Hopefully some of them are useful. And in terms of usefulness, we can think more seriously about COVID-19 situation is actually prevent unavoidable death, save life, and less suffering people in terms of socio-economic outcome as well. I'll end with that. And any question and discussion would be welcome. Thank you.
Thank you, Dr. Leerapan, for such an insightful presentation. What was particularly interesting was how you demonstrated the applicability of systems modeling in the context of hospital utilization and the implication therein for Thailand's universal health coverage, all the while staying true to your unique lived experiences. It was also fascinating to learn about the implications SD modeling can have, not only for the UHC policy process in Thailand, but perhaps extend beyond to other LMICs as well. And of course, the COVID-19 case study is one that is resonant across countries and regions, and of course, warrants a greater discussion, which brings us squarely into the next component of our session, the reflective discussion. Before I start the reflective discussion, I would like to introduce our discussant for the event, Dr. Shohana Shafiq. Dr. Shafiq is a global health researcher with wide-ranging interests, including urban health, nutrition, health policy and systems research, amongst others. She has extensive experience with implementation of research and knowledge translation via evidence generation in the context of universal health coverage in Bangladesh. Currently, she's also leading the Urban Health Research Group at the Health Systems and Policy Studies Division at ICDDRB Bangladesh. With that, I would like to welcome Dr. Shafiq to start the discussion session, providing her reflections and thoughts on Dr. Leerapan's presentation. Over to you, Dr. Shafiq.
Thank you so much, Siddharth, and thank you, Dr. Leerapan, for this excellent, insightful presentation and the discussion on the overview on the system dynamics as well as the system thinking perspective from so many aspects, especially with regard to COVID-19. It was really fascinating. I would like to start my reflections on the talk with some examples from Bangladesh, and then actually going a bit of the Thailand and Bangladesh comparison and the overall in the region, what we have been actually experiencing. So I would like to start with what was actually happening before the COVID-19 happened in Bangladesh, and what was happening during the pandemic, as well as where are we now currently, and what is the way forward. So just wanted to actually share you with at the moment, because of my interest in urban health, and as you know, this any epidemic would hit the urban settings more hard. So that is why actually, yes, I would like to focus more on the urban settings and what was happening in the urban areas in Bangladesh. So in general, in Bangladesh, we have a very nice referral linkages and our health systems in the rural areas of Bangladesh under the Ministry of Health. Whereas in the urban setting, it is the primary healthcare is to be dealt with by the Ministry of Local Government, not the Ministry of Health, but the secondary and tertiary care are by the Ministry of Health. So what's happening in urban settings? So there are lots of actors, and as you can understand that with the booming economic growth in Bangladesh and that is happening in the region, as Dr. Ak also mentioned in his presentation, started with the paddy field and as well as right near the airport. So this is a similar thing that is happening here in Bangladesh at the moment. So at ICDDRB, we have done in 12 cities, in the major cities in Bangladesh, a geo-referral health information system, mapping of the health facilities, where they are located, and the type of services and how they're managed and the cost of services. And there interestingly, we found that how the private sector dominates the urban healthcare landscape. This is very important with regard to the overall governance and issues. So I will coming back to what is happening in the COVID situation in a bit, but I wanted to share and then highlight that what happens when the huge private sector is dominating your urban healthcare, and how it's actually having an impact on the universal health coverage with regard to the quality of services, the coverage of services, as well as the financial risk protection. So in Bangladesh, we have very high out-of-pocket expenditure, and urban poor actually, like because of the lack of primary healthcare services, urban poor seeks care from the informal sector, informal private care, like pharmacies. So they're actually, these are the dynamics actually what is happening in Bangladesh in general. And with regard to the equity perspective, so there's lots to discuss with regard to governance, the regulation, and the referral linkages, because there is very few referral linkages in urban settings from one sector to another. And as I can say that as Ministry of, not only the Ministry of Health and the Ministry of Local Government, many other ministries, as you all know, that health is has to be think beyond health. We have to include the health in all policies, especially it's in the complex urban system where system dynamics and system thinking is absolutely necessary. Because when you zoom out, and you have to actually, with the system thinking perspective, you will see it's actually of course, the immediate the determinants of health and all the risk factors are behavioral level. But when it comes to the structural level or the policy level, you have to think of the other ministries and beyond health. So thinking about that, so there was the Global Health Security Index that in 2019 there was a global study was done, and in that there was one component of pandemic preparedness, and Bangladesh ranked very low in that Global Health Security Index. We got only 27 out of 100. So, so I just wanted to share with all of this aspect, and like Dr. Ak was mentioning, that the compartmentalization. So what we saw that it's not only different ministries, but also within this health ministry, there are lots of compartmentalization within health. So this was actually the general situation before the COVID happened. So we were unprepared for a pandemic. There were a lot of lack of coordination, and there were many actors with very little referral linkages. And for urban poor, there are very little services. As I mentioned, that because of the lack of, I would say, the understanding or the demand for services was also very low. As in general, the citizen engagement and this kind of modality is not very common. So that is why the citizens do not have a voice to ask for services or something in an organized manner. So when in 2020, the first in March 8, 2020, the first case of COVID was identified in Bangladesh. And during April, the country actually decided, the policymakers decided to go on a general holiday. So the policymaker called it a general holiday, not a lockdown. So, and to tackle or as a preventive measure for COVID-19. And that actually gave a mixed kind of impression, because then people thought that we can actually move, because it's a holiday, we can be with our family in the rural setting from urban setting. So there was lots of movement from within the country. So as you understand, the point of entry for a pandemic is the airport and all the border. So from there, actually, it's like Dhaka and all the other bigger cities that has empty. So we did very poorly with regard to the contact tracing, with regard to the quarantine and all this kind of thinking, and as well as the testing facility. I would like to highlight that because of the lack of awareness, generally among the poor, especially among the urban poor, there was an understanding that it's a disease of affluence, or it's actually happening only for the in the upper socioeconomic status of Bangladesh, because the testing was not universal. So that is why only the upper class people was actually getting. And what was happening at the beginning, the private sector, because like I mentioned before, because of the lack of regulatory authorities, the private sector denied to provide services, even though actually when there was need. So it was only the very few government health facilities that was actually ready to provide services. So there was huge demand for services while there was hospitalization needed, and Bangladesh health system was about to collapse, the hospital and all these things. So Dr. Ak was mentioning about how, based on the population need, how it has to be actually strengthened. The primary healthcare or the prevention is necessary. Otherwise, this like the Siriraj hospital, that there are big hospitals and it will be expanding and expanding, but ultimately they will also collapse, because Bangladesh has the highest, most densely populated country. So we actually, if we do not focus on the prevention, so this burden, so the delaying the curve, that is I would say the flattening of the curve, that was absolutely necessary for Bangladesh, and so that was a lot of. So what another aspects was in Bangladesh that was happening during COVID, that as you know, that of course, Bangladesh, with regard to economic development, so we depend on the private sector, and ready-made garments factory or the export-oriented factories. These are one of the major kind of the industry that is actually bringing the GDP. They are the provider of the GDP per capita, the growth of the economic growth of the country. So, so that because of and they're very important lobby to the policymakers, and they kept this open, the factories open. So there was another misleading kind of information going from different ministries. So while the Minister of Health was asking to implement the lockdown, it was not Minister of Health's responsibility to implement the lockdown. It was other ministries, the Home Ministry. And while the Commerce Ministry, because of the economic kind of constraints, they wanted to open the factories and they run the business. So there was lots of lack of coordination. So what we saw actually during COVID, that because of the lack of coordination, or as we all know that organizing or pandemic management needs a whole of a society and whole of a government initiative, but that was actually very much lacking in Bangladesh. So that is why what we saw that lots of after a few days, so there was nobody actually was listening to or paying at or not following the directives of public health directives or the public health precautionary measures. And after the pandemic, or when there was a reduction, so then it comes for the vaccine diplomacy and with this in regard. So there was lots of challenges with this with regard to vaccine hesitancy, as well as building confidence because of the lack of citizen engagement in this area. And as Dr. Ak was mentioning about the human resource and how their capacity needs to be built, and this was same in Bangladesh situation. The doctors, of course, the population and physician ratio is very poor, especially with regard to COVID, with regard to pandemic preparedness and management. And what we see in the second year, in 2020-21, it was not only an urban problem, it was spread to entire country. So this year with the Delta variant, because it was coming from the border, and it was actually from the western part of the country, and then it was actually to the other area. So the dynamics, it was not only concentrated in one area, but also in different kind of area. So finally, what the lessons I've learned from Bangladesh, that recently we are seeing a lots of system kind of approaches the people are getting interested in, because there was the compartmentalization. There are ICDGB and many other colleagues, we have been actually advocating for this exchange between the government as well as different ministries for coordination. So that has been strengthened. And for the evidence that are being produced by the research organization like ICDGB are more being used by the government. So there is recently we are seeing lots of exchange between the government, evidence producers as well as evidence users. So so this is actually something that it's not only happening with one perspective of the COVID-19 management, but also some taking up some urban health strategy and implementation of the urban health strategy. That was actually pending for a long time. So one urban health strategy was created in 2014, but in 2020, it has been actually approved finally, because of the COVID-19, people understood that it is the importance of it. And finally, I would like to mention that there are a lot of interest in the capacity building as well as investing in the human resource for health, like Thailand, and for identifying this as one of the major aspects. So with regard to the production, deployment and retention of this human resources, lots of research are happening, and our development partners as well as the policymakers are taking interest in this. So I hope that in future, Bangladesh will do better job in pandemic preparedness as well as managing a pandemic, and lot to learn from Thailand and of course in developing country with regard to universal health coverage, particularly for urban health. So I'll be happy to take any question with regard to Bangladesh, but maybe I can actually to comment after some time if there's any specific thoughts. Thank you. Over to you, Siddhartha, and if there is any other question is there. Thank you.
Thank you, Dr. Shahana. Before we move on to the Q&A session, Dr. Leerapan, Devaki, if you had any reflections or any follow-ups to the discussion that Dr. Shahana started, maybe we can have like a small space for that. Dr. Leerapan, did you want to start?
Either way is fine. If you want to add something and I can kind of answer all together, that would be great. I'm trying to type the Q&A with the chat first, but if we have time, I can share it live here as well. Up to you.
Okay. I think then we can move on to the Q&A session then. That's all right. Okay. So the first question, Dr. Leerapan, is to you. We were wondering how the intersectionality aspect that Dr. Shahana was mentioning, if you had any experience with that. For example, you mentioned COVID, the socioeconomic toll that, COVID was major in Thailand, but there were also some subsidies that were offered for losing employment. So if you could speak a little to that.
Could you repeat the question, please? I think my internet was unstable. I lost your voice for like
yes, no worries.
Yep.
No worries. We were wondering about the intersectionality aspect that Dr. Shahana mentioned. For example, in COVID, you mentioned that the socioeconomic toll of COVID was major in Thailand, but there were some subsidies that were also offered for those that lost employment. If you could give any examples of some intersectional efforts where ministries perhaps collaborated and speak a little to that.
Yep, sure, thanks. In fact, it's quite important because let's say last year, most people would react to the COVID-19 as a public health emergency, not just Thailand, but all around the world, I think. So people don't think the complete big picture, right? As system thinking that it actually impacts the economy quite deeply, particularly in Thailand, where again, we depend perhaps too much on international trade and international tourism, right? So people lose job. And in fact, there's a case that I actually published this case with some of my colleagues in Thailand and also in the US, that because they lose job and not enough subsidy during the Thai New Year in April 2020, a lot of domestic migrant workers in Bangkok, which is the epicenter back then, cannot live in Bangkok anymore. They lose job, expenditure is high, so they need to travel to their hometown nationwide. In fact, spread the disease nationwide, right? I think that was the case in India as well, with the big city domestic migrant worker and going out, right? So you can see the first lesson is with system thinking, there is no side effect. It's actually unintended consequences that if you think about it, you can create a policy to kind of curve out such adverse consequences. The Thai government later tried to do that. We have a lot of subsidy last year, but not. Economists say, I'm not an economist, but economists say a lot of people kind of not cover them and in access to this kind of help. There's some coupon for people to buy food and products, half from the government paid, and then they pay out the pocket only 50%, something like that. For middle class, they actually try to promote them to go traveling within the country because there is no tourism from overseas. So my wife and I actually got that coupon and we spent in a hotel in the southern coast just to see how things actually getting pretty bad in Phuket Island actually. But it actually ran out of the government said, at least, I don't know if it's true or not, but they kind of ran out of the fiscal space. The subsidization is not much this year. In fact, we get an even worse epidemic this year. So you can think that a lot of people are suffering, and that's when a lot of sector kicks in, not just rely on the government only. Social enterprise, charitable organization, community effort actually are the key. People help themselves and sometimes linking with the government, sometimes not. To me, that you can think about it as a role of multi-sectoral engagement in this complex problem solving. But I would say it could be even better if this is not just filling in the lack of government intervention, but they should think about perspective that this sector bring along something that government sector doesn't have, and also kind of complement something that this sector doesn't have by the government authority and power. I stop there. I guess this kind of thing can be discussed for days, right? But the modeling can help because we can add, this is not just lockdown, but also lockdown plus subsidization for employer to help their employees, right? So we can predict that it's gonna not provoke the domestic traveling or mobility that actually spread out the disease. So it actually impact both economic consequences and epidemiological outcome as well.
Thank you, Dr. Leerapan. For the next question, we were wondering if you could explore more about the application of systems thinking in your case and what that can help to address the silo mentality or mindset of policymakers in Thailand. Did you have any reflections on that?
You want which version of myself, the optimistic one or pessimistic one? Or maybe realistic one, I guess. A lot, if you Google it, actually, there's some people wrote about the challenges of applied system thinking in health policy process, which imply for sure it's not going to be easy. There's a lot of difficulties, of course, but familiarity is one of them, right? I would say in terms of modeling, COVID actually helps because there's a lot of modeling around in the world, not just domestically. You talk about Johns Hopkins, you talk about UC of Washington, and a lot of people kind of refer to not just the data, but also the empirical data, the daily reports, right? But also the modeling to predict for the future. But by itself, the modeling, it can, without a good reflection, good education, conversation or dialogue, if you will. Some would say it could lead people to something like a video game syndrome. You just plug in, change the knob, and then the result's going to be changed. And you try to win the games. What is the best outcome without understanding the mechanics behind the causal link? What actually the leverage point within the system that you need to put more emphasis on, things like that. So if you ask me, it's a good starting point. But you just put the modeling out there and hopefully it kicks in with everyone engaged. It's not going to be that way. I think it requires a process of getting people familiar with it, understand the insight that come out of it. And as I said, a good reflection and dialogue is actually needed. And I guess that's one of the reasons why I work with the mass media in Thailand, try to communicate this stuff to the public. In fact, I got a lesson learned myself. Most people in system thinking would think that the causal loop diagram is actually easier to understand compared to stock and flow diagram for systematic modeling. But the reporter who worked with me, she said that, Professor, this is not easy. This is confused to me, the causal loop. There are too many circles and arrows, things like that. Turned out that she liked the analogy of bathtub and understanding that policy can be shaped by turn on and turn off the valve that inflow and outflow of the bathtub. And we actually got not many bathtubs. We basically just one less infected people, right? And maybe hopefully no one dead, which we can prevent by some certain policy. And with the work of reporter, which they actually quite good in terms of communication compared to scholar researcher, right? Mostly generally speaking. It can actually spread the word, and that indirectly come back to the policymaker to listen what actually people talking about. So from my experience, you need to create a dialogue to create a sustained conversation about why we shouldn't make a short-sighted decision, but more like a comprehensive analysis before creating a policy decision that actually impact a lot of people, like in situation of COVID-19. Hopefully that answered the question.
Yeah, I think so. I hope so. But that was really comprehensive. Thank you. We have another question, Dr. Leerapan, is whether social determinants are taken into account when systems dynamics models are developed, or are these models restricted to within system parameters? Also, once relationships have been established, there could be multiple pathways through which interactions can take place. How are these considered in these models? Would you elaborate on that?
Certainly, the first question is a bit easier to answer. The right answer is it depends. It depends on what kind of model we want to build, what kind of problem we would like to solve. If it is something that has to be related to social determinant of health and you're not including them, basically your model is not going to be valid, right? But on the other hand, if you want to work on something that kind of very focused, let's say matching ICU capacity and the predicted severe cases of COVID-19, and think about how would that compete with other severe cases from other disease, the non-COVID patient, right? For that particular question, it might not be necessarily touch upon social determinant of health at all, because most of the determinant are kind of medical care, right? I guess this is the concept called system boundary. We're not doing the modeling of the whole health system because it's actually impossible. It's too complex. It's too many variables, moving parts, right? But we actually model the problems and problem solving. And usually the whole things that create the problems or can help solving the problem is considered the system that we look at in a particular model. So that's the first question, I guess. The second one, I lost already. Siddharth, sorry. What was that?
Sure. The second question.
Remind me, please.
Yeah, the second question was, once relationships between interacting variables have been established, there could be multiple pathways through which these interactions can take place.
Sure.
So how are these considered in these models? How are these interactions considered in these models?
Well, it depends on how the people who ask the question understand the model. I'm sorry to point out that way. For the beginners, when I teach this kind of stuff, I would say modeling is a process to help you think clearer. So if from X is going to cause us Y, but you think that X might, if the X increase, it could increase the Y, and that's a causation. But sometimes X increase, it actually reduce the Y. It's a good insight that there might be two pathways that X can impact Y, and you have to model it that way. And you go check the literature how actually X can impact Y in a different ways, right? Sometimes you don't work with the evidence, you work with the stakeholder. You actually go to ask them in what scenario, in which context X actually increases Y, in which context X actually decreases Y. Or sometimes both of them are increasing Y, but by different means, right? If you talk about human behaviors, we have a good implementation research framework out there. You can just adopt them, right? Sometimes it's actually driven by motivation of the people. Sometimes it's actually not motivation, but capability, competency, knowledge, skill. Sometimes even people have skill and motivation, they cannot perform that behaviors because they lack of opportunity or infrastructure. You have to diagnose what actually the situation in your problem solving modeling. I guess that's a starting point. But for the advanced people who do the modeling, of course, this is a way have to check with the evidence, and also we have to have a reference mode, what actually more important, because we cannot model everything. We have to have some sort of the weight of what actually we consider validity depends upon it, and then the other would be kind of secondary. Thanks for the question. Quite deep question though.
Thank you, Dr. Leerapan. I think there's another question. How long have you been using systems dynamics modeling in your work? And would you say it is easy for the application in medical care?
How long? Let me say this for people who are interested. I got PhD in health services research, but I did not do system modeling as my PhD dissertation. I just learned something about complexity design, system thinking, have good enough background. My decision is actually econometrics. And then along the way, I see this is quite important, quite fascinating. So with some background, I took classes, go to the conferences, did workshop and things like that, and talk to enough people and have opportunity to engage with a lot of good researcher and modeler within Thailand and international community as well. So I'm not sure, maybe 5 years or 5-6 years about that, not longer than that. And it's not going to be that difficult, but not that easy either. So you need a good, I would say, learning environment, which is not necessarily as a school, but mentorship and also good colleagues to work, help each other. And for some reason, I don't understand quite well, but in a good way, people who are doing system thinking usually help each other. It's a nice community so far, so good. So anyone interested, please welcome join Systack and other network that we can help each other spread out the good news and help each other doing a better job.
Thank you, Dr. Leerapan. I guess we can have one final question, just cognizant of time. Graham Miller asks how you determined the boundaries of your system considered in your inquiry. Did you use something critical systems heuristics related, or was it more? Yeah.
Oh, that's a good question. If you talk about what actually cognitively or intentionally, I'm not sure. But let me try. For the workforce model, for example, I think my team was bounded by the research question of what actually determined the mismatch between the demand and supply of healthcare workforce within the domestic market of Thailand. So you actually talk with people, of course, in group model building, and engage with the literature who actually talking about the labor market, healthcare services market, which is including education of workforce and also healthcare organization who hire the workforce both for medical service and public health, right? So I don't know, maybe it's kind of practical or perspective, but I'm not sure. But we all, using bounded rationality, right? Whatever we perceive might be related, we include on it, but also how it's going to be, how the data is going to be available. Some concepts are not measurable, even it's quite important. Proxy measure has to be included, things like that. So system boundary is quite a critical issue of any model. But again, as I answered the question earlier, focus on the problem. Would you include everything? No. Would you try to include all things that might impact the problem? Yes. Now it's not very objective, sometimes quite subjective. And eventually when you run simulation modeling, it's gonna help, because if your business as usual model cannot predict the past, something might gone missing, or something might be wrong in terms of data variables, values, right? So you can use those kind of stuff to help you define system boundary a bit better. So I guess that's from the workforce piece. From the COVID, is quite fascinating, because problem is a way, let me say, COVID impact everyone in society. So everyone have different concern, right? So you need to talk with them. Today we're going to talk about ICU capacity. So of course, I ignore the SDH, right? But if you talk about health equity, how COVID-19 impact health equity, and you're not including SDH, your model is going to be wrong. Yeah, it's going to be invalid. It couldn't be more wrong, right? So now you have to be good at communication, both after you finish your modeling and also when you engage with people during the process of initiate the modeling at first as well. So I guess that's more like a pragmatist, I would say, but there might be some people think more seriously about what approach I use. I would love to hear what Graham said about this approaches.
I think Graham has actually asked a follow-up question, and he's just curious about, given the value of your discussions on the CLD with the government, would you consider SSM to also surface perspectives?
subsystem methodology, you mean?
Yeah, I think so. Yes.
I know about that, but I don't think I follow precisely the SSM. It's more like coming from the stream of literature on group model building. Some variants called participatory system dynamic modeling, some variants called community-based system dynamic modeling. But compare and contrast, it has the strength and weaknesses using SSM versus the SD with group model building. Pretty close, but not exactly the same from my understanding. And SSM has maybe many versions, right? It depends on which version you talk about. The recently updated version is getting closer to what I presented, I think. Yep.
Thank you, Dr. Leerapan. And Dr. Shohana, I had one question for you. With regards to systems thinking more broadly, would you say the application of systems thinking in the UHC context in Bangladesh is going to has some potential advantages moving forward, especially in a post-pandemic era? I think that's something that I wanted to know. If you could expand on that.
Absolutely, and that is a very important, actually, way of thinking and looking at the post-pandemic era with so much complexity. And as we all understand, because it's a complex problem, we have to have new tools actually to address these problems, and also get ourselves introduced to how to use these tools effectively and connect with others and explain these tools, how to use this in their everyday life. So one aspect I would like to highlight with regard to Bangladesh, and as before the COVID-19, I think this was actually not only Bangladesh and in general globally, there was a very distinct with regard to literature and the implementation, the very distinct segregation of the communicable diseases and the non-communicable diseases. And Bangladesh is going through an epidemiological transition like Thailand. And I actually did my MPH fieldwork in Khon Kaen, Thailand. So in Public Health University, Khon Kaen University. So, and was pretty much on a similar topic on epidemiological transition in an urban setting. And what we saw in COVID-19 pandemic, that there is a gray area. People who have non-communicable diseases, they're at high risk for morbidity and mortality, and like hospitalization and mortality. So this actually brings the emphasis on the epidemiological transition and this system thinking approaches and look at it and include the social determinants of health in a more broader way. And I think it's absolutely necessary that we, as we go forward, we use these tools and understand it better. And currently at the moment at ICDDB, with support from SIDA, Swedish SIDA, we are actually doing this exactly work, and with capacity building on system thinking approaches and what tools to be used, as well as the interlinkages of different systems through one health perspective, the environmental health, the animal health, and the human health, how they interact, as well as the health systems and the food systems interaction, and how actually without these different systems, if we do not all the system interact, ultimately we are not going to achieve the proper human health or achieve universal health coverage, and because of the high burden from the non-communicable diseases and the catastrophic health expenditure that comes along with it. Thank you.
Thank you so much, Dr. Shohana. And there was one final question with regards to how we can learn more about systems dynamics modeling and maybe the tools and other things that are available, which I think I'll just delve into while talking about Systack. So thank you everyone for your questions, and I'll quickly move on to the next portion, which is just going to be briefly talking about and acknowledging an initiative by the Alliance for Health Policy and Systems Research called the Systems Thinking Accelerator, or Systack for short. Systack actually inspired the content and network for today's session. And over the past few months, DP and I have been assisting with the development of this Systems Thinking Accelerator for fostering a community of system thinkers to engage and collaborate to elevate the field of systems thinking for improving health. Systack has been working backward from the objective of improving the use of systems thinking across multiple avenues across the sphere of health. We've been engaging with practitioners, decision makers, and researchers across the world. Broadly speaking, Systack seeks to be a platform for advancing systems thinking in health, an amplifier for systems thinking in policymaking and practice, and a community of systems thinkers and an opportunity for engagement across a broad global community of practice. With what started with 5 regional institutes during its conception, the Systack network now has representation from multiple countries across the regions and the globe. Over and above existing groups within the wider community, this map shows just a glimpse of the Systack network that is part of the Alliance Hive, which is an online networking platform that serves as a space for systems thinkers to connect, network, and engage across regions. This is what Dr. Leerapan was also talking about during his discussion. Over the past few months, Devki, I, Dr. Leerapan, and Dr. Shahana have also had the privilege of engaging with and learning about systems thinking from expertise across the region as part of conducting a needs assessment. Despite COVID-19 causing a plethora of procedural delays and unforeseen challenges to our stakeholder outreach, we have been encouraged by the few stakeholder conversations that we've had so far. And the consultations have enabled us to identify regional priorities in terms of how best to define and frame systems thinking. The accelerator also has been able to figure out what the needs are across different regions and what are the needs it can address, and also identify domain areas and modalities that would lend themselves to regional and even global work on systems thinking. We've received a lot of positive feedback from the consultations that we've had, and that's been pivotal in informing Systack's approach. So far with Systack, we, along with each of the regional institutes, have conducted the aforementioned needs assessments to learn about existing efforts and challenges related to implementing systems thinking for improving health and in identifying opportunities for knowledge sharing. These assessments have been crucial for developing and understanding the needs and demands of systems thinking among practitioners, researchers, and decision makers. To take some of these conversations forward, Systack has also launched Seeing the Full Picture, which is a special podcast series about systems thinking for health system strengthening, hosted by the Alliance for Health Policy and Systems Research, which is in collaboration with the George Institute for Global Health. It currently has 5 very exciting conversations, and we hope to add more in the coming future. We will be dropping the link in the chat for anyone who would want to tune in. Through Systack, cross-regional capacity strengthening webinars have also taken place, like the one that we are attending today, across multiple topics. And through Systack, cross-regional research collaborations have been mediated as well. The George Institute recently collaborated with multiple institutes across the region to submit a joint research proposal to NIHR, which was focused on the application of systems thinking in the context of equity in the Southeast Asia region. With multiple regional inputs, Systack has also began co-creating a theory of change to delve deeper into our goals and objectives and realizing our approach. And lastly, in the first week of November, we have the first of many global meetings which convene stakeholders across multiple regions to discuss and engage further in bridging the theory to practice gap in systems thinking. We are always keen, as Dr. Leerapan already stated, to hear from all of you, and would love to take the conversation forward if you wish to engage and learn more about Systack, or even become part of the hive that we discussed earlier. Please feel free to reach out to us and start this conversation. We will drop the contact details in the chat for your reference. So that was a brief overview of Systack, a systems thinking accelerator that's being developed by the Alliance for Health Policy and Systems Research to create a global community of practice to elevate the field of systems thinking. We look forward to your interest and engagement and are excited in taking the conversation forward. We have lots of exciting engagements planned in the near future and would love for you guys to participate. I will request Dr. Nambiar to perhaps add anything I might have missed or deliver a vote of thanks if she's available. Otherwise, we can draw a close to the session.
Thank you, Siddharth. I'd like to take this opportunity to thank everybody for making the time to hear what were just really electric presentations. Thank you so much. Ak and Sohana, it's really a wonderful regional but really global learning opportunity. We're looking forward to having more such events and conversations, as Siddharth also said. I'd like to extend a vote of thanks to him for helping put this event together, as well as Sarika, Gunjan, Jason, and others at the TGI team. We're also grateful to Systack for putting this together. Look forward to doing more of these. Have a wonderful day, everybody, and we'll see you at the end. Take good care.
Thank you. Take care.
Thank you, Devaki. Thank you, Siddharth. And thank you, Dr. Thank you, everyone.